What we're trying to do is to collaborate on the American Cancer Society's statement this year, "You never walk alone." Well, no doctors walk alone either. It takes a village. Remember, I'm using all the platitudes I seem to be able to think of, but it does take a whole group of doctors to treat even one case of breast cancer. Just among my general remarks, I want to say that one size never fits all when it comes to breast cancer. There are any myriad of diagnoses depending on the pathologic diagnosis. That is, when we look at the cells, what kind of a breast cancer it is, because there is more than one kind. What kind of markers are on the cells? How do we treat this? There are any number of options, and especially today, which is really verging on genetic treatment of cancer, more and more we are treating patients individually for that particular genome. So I think it's important that you understand that we can't tell you about how one case will go. And we never necessarily see these doctors in this order, but all of them are very often involved in the care of each and every patient. So you will hear more about what they do as they each come up. I'm going to start off by saying that patients usually start by coming to see someone like me or coming to the Breast Diagnostic Center. Either their doctor has felt something in their breast on a breast examination, although the new guidelines, and we'll talk a little bit about that for those of you who saw, I guess, CBS, ABC, Fox News, and all of those things today, telling us about guidelines for screening. There's not enough time here. I only get 10 minutes, and Judith gets out this huge long hook and takes me off the stage like the vaudeville act. But I want to say that I'm embarrassed to say that compliance for mammography screening is down 27% this year, and it's no wonder, because all of the organizations that deal with it couldn't get together and decide what the guidelines are. And in their ultimate wisdom, the American Cancer Society, an organization that has been fantastic over the years, has altered their statement, which is why all of these broadcasters have had on the radio today a new guideline for breast cancer. We say start every year at 40. The U.S. Preventive Task Forces, I don't have time to explain that to you, 13 men, no cancer doctors, 2 physicians, masters in public health, everybody else is a statistician, decided that women don't need mammograms until they're 50, and then they should have them every 2 years, not every year. Well, the guidelines have changed. They are now, again, starting at 40, or at least talk to your doctor, but definitely start at 45. Do it every year till you're 50, then every 2 years. We still subscribe to the NCI, National Cancer Institute guidelines, and everybody else. Start at 40, do it every year. And I'm going to show you why. Grapes or leaves on small ductules, larger ducts, 20 of them, usually open on the nipple. Cancer can start in the ducts, and one of them is transected or divided here so you can see what it looks like, or it can start in the lobules, infiltrating lobular cancer, lesser in amount than infiltrating ductal cancer. Cancer can start in either one. A duct, when it's transected, has these normal appearing, monotonous appearing cells around it. And then we have ductal hyperplasia, still a benign condition, but these monotonous appearing cells start to fill up the duct, but then they start to get atypical. Some of the cells get too big. Some of the nuclei, the blue part inside of the cell, start to get big, and they're undergoing a change. And when we analyzed our own data, 30% of patients who had atypical ductal hyperplasia eventually got infiltrating cancer. What is infiltrating cancer? Well, first, there's ductal cancer in situ. Another thing you've all read about. There was a huge article, I think it had 4 jump pages in the New York Times about a month ago, about the fact that, quote, we're overdiagnosing breast cancer. This is what they're talking about. One doctor who's at UC San Francisco says, I never take this out anymore. I don't remove that. Even though at the time of diagnosis, 10% of those cases are already invasive, because these areas of ductal cancer in situ can involve the entire breast. We take these out because a percentage of them, and in our practice, it's about 30% of cases have ductal cancer in situ. These abnormal cells finally break through the wall and start invading the remainder of the breast, the armpit lymph nodes, and then they spread around. So We believe this should still be removed, and most people do believe that, but there are clinical trials which we do know that we overdiagnose some, and what that means is some women who get this condition may never get cancer, but we don't know which ones, and until we do, we're going to continue to take them out. What are the risks for breast cancer? Part of this is not showing, but these are breast cancer risks that you can't change as you get older. Cancer is a disease of older women, which is why the current guidelines say keep screening for breast cancer until it is 10 years before the age at which you die of something else. So we say, start at 40 and continue till you're about 85. Those are the current guidelines. A family history. If you have people in the family with breast cancer, you have a problem with risk. Because if you have a mother, a sister, a daughter, you will double your risk if you have a family history with a first-degree relative, and if you have 2 first-degree relatives, you increase your risk by 5 times. What can you do? You can do mammography every year, and you can also get an MRI. I don't have time to further explain that to you. It's important to know that even though you have no family history, you have a chance to get breast cancer. But mammography remains the best thing you can do to screen for breast cancer, as well as a physical examination. Because occasionally women don't get mammograms and they feel a lump in their breast. Mammography is still the best way to go. I still think it should be 40. We have a new kind of mammography. It's called tomosynthesis. We have one of these machines. These are $400,000 mammogram machines for which the government and insurance companies give us no additional money, unfortunately, so we have to raise that money to buy these machines, which are far better than the old digital mammograms. And why? Because the equivalency would be, how do I look for the P in the story about the princess and the pea if I don't have a way to cut between these things? In other words, a breast is a 3-dimensional structure, and we're looking at it in a 2-dimensional image only from 2 sides. But if we could cut through it at 1 millimeter slices, put them together in 16 or 14 slabs, depending on how wide the breast is, we could page through them and find them. And this is what it looks like. This is a regular mammogram. This is 1 image, 1 slab of a tomogram. You're not close enough, but I guarantee you that this little nodule that looks like this one or this one and this one, when you look at it with a tomogram, has a little star-shaped spiculated margin. And it's a cancer. It's not just another nodule. Same thing is true here, and I think it's better seen here. Here's a regular mammogram with a lot of glandular tissue. The black is fat. The breast is made up mostly of fat. But this glandular tissue are those little lobules and ductules I showed you before. But when you take them away with a tomogram, there's this spiculated star-shaped thing, which is a real bad thing. That is almost 100% a cancer. Could be a radial scar, but it's almost 100% a cancer. And so after we see this, we would proceed to do an ultrasound. Same thing is true here. But until 2 years ago, we had no other way to look at it except for an MRI. But here is the star-shaped entity. It's here, it's in here. You would never, ever pick that up for a cancer. So what does it do? All of the things I've talked to you about. We also do ultrasounds. When we see something like this, we know it's a cyst. This patient had a lump in her breast, but when we felt this lump and looked at it, it's gray, not black. Black means the sound can go through it because this is fluid. The sound can't go through this and gives an acoustic image, and then here's some vessels in it. That's cancer. Here again, another image. This is what we look at on a mammogram without the ultrasound, seeing something grayish, taller than wide and irregular. We know that's a cancer. We do a biopsy of that. That's where Dr. Friedlander comes in. All biopsies are now, according to the FDA, the recommendation is they never be primarily removed by a surgeon. They should be removed with a needle by an imaging person like myself, using ultrasound guidance or mammogram if we don't see it. And then, for instance, in this case, you can see there's a little cancer behind here. The black is where we took the tissue out, and we put a little marker in there so that on the day of surgery I can localize that and Dr. Friedlander can find it, and then we do an MRI. There's a cancer here. We did this to look at this cancer, but there was a cancer on the other side, and this cancer was a lot bigger than we thought. So these are the kind of images I deal with, and these are the ways we diagnose breast cancer. Mammography is still your best bet to start with. I want to introduce now a nurse navigator. These are women who really are the glue that holds the place together. I get a lot of the credit, they do the work. These are the ladies who are present with an oncologist when they get their diagnosis of breast cancer, and they are there at the end of the telephone when someone needs to cry, when someone needs to talk to someone. And the old expression, you're not there alone.
Maybe many of you have never heard of navigation, but it started 25 years ago in New York by a doctor named Harold Freeman for people who couldn't get to their appointments or receive appropriate care. So he designed this program and has seen it through. He's still speaking. We just saw him speak last week at a conference, and he's extending his program. Now they're navigating other diseases besides breast. But on the day of diagnosis, we receive the pathology report. The doctors review the films again. We get them back, and an oncologist comes. We schedule the patient to come and get their diagnosis. The doctor will give them a brief description of their disease, and also he will recommend what should come. This is based on the facts that we have at hand at that time. And then we take the patient by their hand and we tell them we are there for them. We're their personal navigator. We will see them through every appointment. We'll make their appointments, make sure they go places their insurance. We'll carry them through. We let them select. So a lot of things are taken away from women when they have breast cancer. Timing, decision making. We show them the surgeon's cards. We let them know about their history, their background. We let them select their surgeon and we make an appointment. Not always that can happen with oncology because it's a very busy department, but we try to help set the patient up. We call them after each appointment. We make sure they're satisfied with the service that they receive. But like Dr. Sachs said, we also are there for them for their emotional support, psychological support. We will send them to places they need for support, whether it be financial, medical. Then maybe their insurance isn't carried by our surgeons. We have to send them to other places. We do that as well. But she was also mentioning about how insurance has changed in approving, mammograms, etc., for older women. I had a woman come into my office, 84 years old, 2 weeks ago. She's a professional, still working, very intelligent woman, and they denied her mammogram, so she paid cash. Well, guess what? She had infiltrating ductal carcinoma. I'm also a breast cancer survivor. I had stage 2 infiltrating ductal carcinoma. I'm here today. We're survivors now. We catch it early, the treatments are changing, and we have great support. And just to let you know, we're out there, we're available, and Torrance Memorial has an outstanding program to provide all patients, no matter what their background, their insurance, if they come into our office, they're going to receive care.
If you look at these statistics here, you can see lung cancer is the #1 cause of death, but breast cancer is #2. So there still is a lot of work to be done. This is the incidence of hereditary breast cancer, and you can see that certain patients need to be tested for the BRCA gene and for inherited traits. The testing for genetic traits is getting better and better. Now we have the BRCA1 and the BRCA2, something called the BRCA+, where we're looking at other inherited traits. And this kind of divides all of these up into certain groups based on your family history. Dr. Sachs already alluded to this. The reason we have breasts is to make milk. So there's 2 basic units of the breast, which is the lobes and the ducts. And so one can get lobular cancer or ductal cancer. Ductal cancer is the more predominant type. And you've already seen this from Dr. Sachs, so I'm not going to go over it in great detail, but this is the evolution of ductal cancer. And you can see on the left is a normal duct, and on the right is a duct that's been obscured by these invasive cancer cells. So one of the questions that I receive from patients, how long have I had this cancer? I was tested last year, my mammogram was normal, did it just show up now? How long have these cells been here? And our best guess is that when DCIS presents, it's probably been there for over 5 years. When palpable tumor presents, it's probably been there for over 8 years. So this pathology has been in the making for years and years and years and years. The most important thing in our office, and whenever we're hurrying to get a new breast cancer patient in, do we have the receptors? This is the personality of the tumor. This is what drives the tumor, and this is what we have to know to try to treat the tumor. There are 4 receptors, but there are many, many more. But these are the 4 that we look at initially. There's the estrogen receptor, the progesterone receptor, the Ki67, which is a growth rate of how fast the tumor is growing, and a final receptor, which is called the HER2/neu receptor. So as you can imagine, there's many different combinations of these 4 receptors, and that's how many different combinations of types of breast cancer a woman can have. The estrogen and progesterone receptor, these are really, really, really important. The estrogen receptor works through the estrogen molecule attaches to an estrogen receptor, and then the DNA is set into motion, and that's a growth pathway for the cell. The progesterone receptor is another receptor that we understand a lot less about. We understand a lot more about the estrogen receptor. When a woman comes in with breast cancer, they want to have an estrogen receptor positive tumor. That's considered a favorable sign. They also want to have a progesterone receptor positive tumor. That's considered a favorable sign. It's kind of like riding a horse, and if you know the 2 reins, you can control them or you can block them. And a lot of the manipulations that we use favor blocking these pathways, blocking the estrogen receptor pathway as a growth pathway. The growth rate, the Ki67, the 3rd receptor, this is very important, and this dictates the speed of therapy, whether chemotherapy is given first, how the entire workup ensues. So a higher Ki67 score would indicate a tumor that's growing faster. It's a proliferation index. And then the HER2/neu receptor. You know, the HER2/neu receptor used to be something that was a little bit feared because this is a very aggressive type of tumor. Now that we have multiple drugs that can block this receptor, namely Herceptin, this is turned out to be a favorable receptor because we have such wonderful treatments for the HER2/neu receptor. Also, if a woman expresses a HER2/neu receptor on her breast cancer cells, since we know the pathway of the HER2/neu receptor, we can block that with different drugs. This is a very busy slide, but you can see all the different pathways of growth that the HER2/neu receptor triggers within the nucleus of the cell. And then that leads to transcriptions of growth genes, which lead to down signaling, which basically make the cell grow. The main drug that blocks this, like I had already alluded to, is Herceptin, and that blocks the cell growth. So what I'm trying to do when someone's in my office is I'm not determining the type of surgery they're going to have, and I'm determining the type of therapy that they're going to have to carry them all the way through and hopefully to cure them. When someone has a HER2/neu overexpressing tumor, then we treat them with chemotherapy first. And that goes for almost all HER2/neu tumors because they're so exquisitely sensitive to the Herceptin-based therapies. Now, one doesn't receive Herceptin alone. It's usually paired with chemotherapy. And when we give chemotherapy before surgery, this is called neoadjuvant therapy. And the last 3 patients that I've had, when they've gone to surgery, there was no tumor at all, which was just such an exciting, wonderful feeling. Do I really need chemo? That's the next question that's asked in my office. Why did I get breast cancer, and do I really need chemo? As you can see, there are many receptors that go into deciding this question. This is called the Oncotype DX, and this is for women that are kind of on the borderline, meaning their lymph nodes are negative, but their tumor's around 2 centimeters, and we're trying to determine, do they really need chemo? And what the Oncotype DX looks at is multiple receptors, including the estrogen and progesterone and the HER2/neu and the Ki67, as I've already mentioned. But it includes a lot of other receptors, and it's kind of like throwing all of these into a blender, and then it gives us a number and determines the risk of recurrence. And we use this a lot now in our office to give women feedback as to whether they really need to go through chemotherapy. What if all your receptors are negative? You know, what if your estrogen, progesterone, and HER2/neu are negative? We refer to those tumors as the triple negative tumors. And again, this just goes to the fact that breast cancer is so different. Every single patient you see, it's such a different pathology for each individual woman. The triple negative tumors are the most aggressive tumors. However, there are new drugs and new chemotherapeutics that triple negative breast cancers are sensitive to. So there is some positive news on the horizon for the triple negative breast cancers. So the treatment. So as you can see, the treatment is really, really based on the personality of your tumor, on the receptors, on the pathophysiology of those growth pathways. What if a woman comes in with a small tumor? She'll end up having surgery and she won't need chemotherapy, thankfully. But we will still employ the blockage of the estrogen receptor. When you look at, this is tamoxifen, which is a drug which is normally used in premenopausal women. This drug was first developed to increase bone density, but lo and behold, it was shown also to prevent breast cancer. And what it really does is it competitively blocks the receptor and does not allow estrogen to attach to the receptor, and the cells die. What about the aromatase inhibitors? You may have heard of these: Arimidex, Letrozole, Femara. There's 3. They're basically all sisters of one another, and one's not better than either any of the others. It's just basically based on side effects and how a woman tolerates it. Meaning a woman may tolerate one very poorly, and then being switched may tolerate the next one with ease. Blocks the androgen conversion to estrogen. If you're postmenopausal, you may say, well, I'm not having menstrual cycles anymore. Where am I getting estrogen from? And estrogen is still produced by fat cells, and it's also still produced by your adrenal gland. So it's still blocking those effects by working on an enzyme. Chemotherapy, nobody wants chemotherapy, and we understand that in our office. And we really try to support patients in this, going through it. From the very first day all the way through, we have patients end up having chemotherapy teaching. They have a nurse assigned to them when they're receiving their chemotherapy who follows up and calls them the next day, and quite a big support staff, because it's a lot to go through. When a patient is given chemotherapy prior to their surgery, such as when you have a HER2 new expressing tumor, that's termed neoadjuvant chemotherapy. So generally speaking, the woman would receive all of her chemotherapy prior to her surgery, and then she would have her surgery at the end. And then she may be placed on one of the breast cancer pills after, depending on those estrogen receptors that I was showing you. Adjuvant therapy means it's given after surgery. And I think that's confusing for women when they come in and say, well, the surgeon said we got it all. It's all gone. Why am I getting chemotherapy? What are you doing to me? I thought I was done. I've done the surgery and it's over. Well, this is really based on their risk of systemic spread, and a lot goes into that. Before, it was just easy equation: 2 centimeters or bigger, lymph nodes positive, you're going to get chemotherapy. But now there's a lot more to it. We look at all those receptors, we look at the growth rate, we take that all in total, we look at the woman's health, her other risk factors, her past medical history, her age, where is she in her life, what's happening, and we put that all together and individualize that for each woman. But the reason that women get adjuvant chemotherapy is there is always the chance of distant spread. And our goal is to cure patients. We want them to be alive for as long as possible, and that's why adjuvant chemotherapy is given. Metastatic disease. Unfortunately, some women are diagnosed with metastatic disease, but there is still a lot to offer those women, especially for women that have the HER2 new receptor or other targets. They can be on therapy for a very, very long time, and it can help control their symptoms and can really benefit the patients. So again, Herceptin-based therapy is something that we would give in a neoadjuvant fashion. Triple-negative tumors, or tumors that are growing very fast, we like to give chemotherapy to first as well, prior to surgery. So normally when I see patients in my clinic, I will see them before the surgeon in these cases, where we're considering giving them chemotherapy before. But we see patients whenever, and we'll see them whenever they come. We see them before, we see them after, and all the way through. And we follow all patients for 5 years or even longer.
Just want to take a quick minute to say how lucky I feel to be part of what I consider all of these ladies to be the dream team. When I came to Torrance Memorial, it was my first time working outside of an academic environment, a university program, and I really didn't know what to expect. And without Dr. Sachs, there would be no breast diagnostic center. And without the breast, yes, absolutely. Bravo. She's my hero. Yeah. And without the breast diagnostic center, we wouldn't have a multidisciplinary